Good evening, everyone, and welcome to today's Facebook Live session. My name's Sam Chikoski, and I'm the Sales and Marketing Manager at the JCN, and I'm just going to run through a couple of bits of housekeeping before we get underway with today's session. So today's session is sponsored by Ergo, and the title of the session is Understanding the Role of Silver Dressings in Wound Infection. And we're very lucky to have Val Edwards-Jones as our speaker. And Val is the Emeritus Professor of Medical Microbiology at Manchester Metropolitan University, and also the Visiting Professor for Skin Infection and Infection Prevention Institute at the University of Huddersfield. Welcome, Val. I'm just going to go through a couple of bits before we get started. So first of all, the certificates. We will post a certificate link at the end of the session, so that will be in the comments and on the slides. You'll be able to download a certificate for your revalidation after the session's finished. Do make sure you get involved with today's session. Put lots of comments and questions in the comments section. I'll be back at the end for a live Q&A, and I'll be asking all of those questions to Val. And if we don't get through all of those questions, then we'll be able to answer those in the next few days. Do bear with us if there are any technical issues. I'm sure there won't be, but you'll notice that we are remotely recording this, so if there are any issues, the team will be on hand in the comments section as well. Any other questions, put them in the comments. Enjoy the session. I'll see you at the end for the live Q&A. Thank you very much.
Okay, thank you, Sam. Thank you to Ergo for inviting me on this session, and also thank you to Journal of Community Nursing. It will be a good session, I hope, and explain and help you understand the role of silver dressings in wound infection, and hopefully it will generate quite a lot of questions at the end. So one of the questions I get asked a lot is, why is infection an important issue in wound care? Well, we know in acute wounds, there's about 5% of all wounds become infected, whether it's after surgery or burns, etc. And we know they're usually a single organism and resolve quite easily with good antibiotic and wound care. However, in chronic wounds, it's not as simple. There's a very, very high prevalence of biofilms in chronic wounds, and research has shown there's up to 80% of all chronic wounds have a biofilm in situ. For those people who are not aware of what a biofilm is, these are microorganisms that are usually in mixed culture, stuck firmly to the tissue and encased in a matrix. This makes removal of biofilms quite difficult, and they will sit in a wound quite happily, undisturbed, unless someone decides to do something about them. So infection's one of the most frequent complications of a non-healing wound, and it's the goal of everyone to try and get those chronic open wounds healed. The complications of wound infection, obviously with delayed wound healing, you get anxiety with regard to the patient's family. It causes confusion and stress. Sometimes it causes an awful lot of problems with quality of life, especially with regards to having an open wound, sometimes with a lot of exudate and with a quite horrible smell on some occasions. With some of the wounds, if they're not addressed quite quickly, it can lead to hospitalization, certainly amputation in the diabetic foot, and potentially death as a complication with sepsis. It will also delay any planned surgical intervention if any wounds are chronic and open. For example, with treatment for breast cancer, if you've got an open wound, it can certainly delay chemotherapy. So it doesn't just cause delays and anxiety for the patient, but it also causes a lot of anxiety for the NHS staff. Not so long ago, it's about a year ago, a group of us sat and put together a best practice statement. And we were asked to do this because there's been a lot of misconceptions about the use of silver in wound care. It's been used since the 60s in burns with something like silver sulfadiazine. And prior to that, it was used as silver nitrate from somewhere in the 18th century. We even used to use it in newborns with gonorrhea in the eyes. So the silver best practice statement is well regarded. It's been put together by a panel of experts who are ranging from nurse consultants, matrons, so how it's used within the community, tissue viability specialists. We also have podiatrists involved in the panel. So the silver best practice statement actually talks about the role of silver in wound care, dispels any myths and truths, introduces a new tool to help with identification of local wound infection, the Tilly score, and will provide guidance to healthcare professionals about its appropriate use in clinical practice. And as you can see, they're the names of the people who were involved in putting together the statement. Why was there a need for this best practice statement? Well, silver has been used for many years, but there's been a lot of confusion and misconception around the use of silver in recent years. Some of this was because of studies that had been done, very poorly designed studies that said silver had no place. It's also a lot of problems with regards to understanding exactly how it works. There's some issue with cost of the dressings. And obviously, it's a cultural change that's needed. And in order to drive forward the use of really well-evidenced dressings, what we need to do is to give information and education to the people who are practicing and using these tools, such as silver dressings. There's a lot of confusion with regards to the 2-week challenge approach. And people think that you can only use silver dressings for 2 weeks, which is actually nonsense. The idea of the 2-week challenge is to make sure that the person who has a wound is continually reassessed, so that you will assess the wound, debride and clean it if required, apply an antimicrobial dressing, and your first choice may be silver, and then you leave it as the treatment plan over 2 weeks. If the wound is improving as you take down the dressings, well, you may want to leave it on for another week, or you may want to stop it at that point. So the 2-week challenge is literally an indication for you to continually assess the wound. There are 4 cornerstones of treatment: the pathophysiology, so this is the whole holistic treatment of the patient, making sure they're in the best state they can possibly be. The second cornerstone is wound bed preparation. And I think we all know about time, and there are other acronyms that can be used, but it's about looking at the whole wound bed. Is the slough present? What is the actual peri-wound look like? Is there lots of exudate? How much moisture? So it's all about preparing a wound for its treatment plan. And some of the wound bed preparation may involve debridement and cleaning. And here the cleaning can be of the wound itself, or the peri-wound, or the whole limb. And obviously, the 4th cornerstone is infection management. If you go to a wound and find that there's a local wound infection present, and I am going to talk about that in a moment about its diagnosis, you need to really think very carefully about which dressing you're going to use, for how long, and when you will reassess. You also, certainly if you're dealing with a chronic wound, may well have to think about an anti-biofilm strategy going forward. So the wound may not look infected, but as I've told you before, the data now shows that up to 80% of all chronic wounds will have a biofilm. You have to remember that not all silver dressings are the same. And what I mean by this is that the carrier dressing, the background, whether it's a foam, a hydrofiber, or whether it's got other attributes, this is one of the most important choices that you should make when choosing your relative dressing. You need something that can handle exudate, that won't stick to a wound, especially if the skin's friable. And the dressing materials are also important. some of the newer dressings actually have a cleaning action themselves with regards to their fibres. Silver itself is available in a number of different forms, and the amounts in the dressings vary considerably based on the actual form of silver. So you could have an elemental silver, you can have an inorganic or an organic compound such as silver oxide or silver alginate, it may be silver acetate, and it may be nanocrystalline silver. And when making silver dressings, you can't just add any type of chemical silver to the dressing because of the interaction chemically. So if you're looking at a foam dressing, you may well only have a range of different silvers that can be used. But actually, the most important attribute of all silver dressings is the availability of the silver ion Ag+. When a silver compound dissociates, it releases silver ions, silver Ag+. And these are the active components, and these are the components that are antimicrobial. So the important aspect of a silver dressing is the availability of the silver ion. If you have a compound in the dressing and the silver ion isn't being released, well, in that case, the silver compound isn't active. It's the silver ion that's important. But what's also important, especially where silver dressings are used in the community and in other healthcare environments, is the cleaning action within the dressing. It's not just the silver. Most of the silver dressings work by exudate passing through the dressing and activating the silver ion. And most of the killing of the microorganisms occurs within the silver dressing. Many of the silver dressings do not donate silver to the surface of the wound. Most of the mode of action occurs within the dressing. So therefore, a cleaning action of the dressing is very, very important. And this will facilitate continuous removal of the biofilm, the matrix, the slough and exudate. And obviously most of the killing occurs within the dressing. And this is just an example to show you that this is silver sulfate. And if you get hydration with the effect of exudate, you get the release of silver ions and sulfate ions. So silver dressings, it's very, very important that you select silver dressings based on the holistic assessment of the patient and the wound. If the patient needs a foam dressing, you may need to use a foam dressing that includes silver. And all of these will be based on your individual patient. So let's look at some silver best practice statements, myths and truth. So when we have a look at a myth, one of the very common ones is that silver dressings will cause systemic toxic effects. And this arises from the use of silver sulfadiazine many years ago, where very large quantities of silver sulfadiazine was placed on a wound, and you may well have got argyria occurring. Nowadays, concentrations of silver are very, very well determined, and we do know that silver is relatively non-toxic and in some cases can be anti-inflammatory because it actually does inhibit metalloproteases. And we also know that in a wound, there's very, very little silver absorbed across the wound, so it doesn't cause that much problem systemically. A second myth is that silver is not cost effective. And obviously behind this is the cost of the dressings themselves. But actually there's been a number of studies being undertaken, and nearly every study that's been produced just demonstrates that silver dressings are actually cost effective because you need less frequent changes, less nursing care, etc. And finally, one of the myths is that the level of silver in the dressings are important. And whereas this, I can understand where this myth has come from, because it's the amount of available silver that's very, very important for its antimicrobial action. And sometimes this goes hand in hand with the concentration of the silver salt that's actually present. So when we do studies in the laboratory, certain levels of silver are required to kill certain microorganisms. But what we do know is that nearly all the manufacturers' dressings have to go through very rigorous testing, and that we know the availability of the silver ions within a wound is far more important than the actual levels of silver. So if we move on from silver dressings and we look at diagnosing local wound infection, these bring about their own challenges. In acute wounds, I think it's relatively straightforward. Certainly in surgical sites, you get typical overt signs of infection which follow the inflammation pathway. A patient then will probably have a swab taken and antibiotics prescribed. However, in chronic wounds, it just isn't as simple as that. And clinicians need to rely on other signs and symptoms to help diagnose local wound infection. And actually, although there's been an awful lot of papers written about diagnosis of local wound infection, until now, there's been no real consensus on which signs to actually use to help with this. If we look at the infection continuum, what we find, and this is from the World Union of Wound Healing Societies, a best practice, and this is an international consensus, and what we see here is contamination up to systemic infection. What you find is that nearly all wounds become contaminated, and certainly in chronic wounds, nearly all of them are contaminated. A microorganism then will start to take home and start to feel very comfortable within the wound, and they start to colonize the wound. So they actively start to increase in numbers. During this stage, no antimicrobials are needed, just good cleaning and debridement if necessary. However, local infection is where you start to get overt signs of infection. And if this is left untreated, you can get a spreading infection where it goes into local tissues, and then in systemic infection, which can lead to sepsis. From local infection up to systemic infection, we do need intervention, and it's nearly always caused by a biofilm. And within the biofilm, you may or may not have pathogens present. It may be sheer numbers that's causing the problem. But from a local infection up to systemic infections, you need to have intervention. You need either a topical antimicrobial, or in the case of spreading and systemic infection, you will need systemic and topical antimicrobials. And because of antimicrobial resistance, we as a group are trying to reduce the misuse of systemic antibiotics. So there's no point using systemic antibiotics in a wound that's just not healing. It may well be that it's just heavily colonized, that there's a biofilm present. There's no genuine infection, but you need to intervene with debridement and cleaning. So a panel of experts from across Europe sat in a room or several rooms over several weeks to put together the idea of the Tilly score. And Tilly score stands for Therapeutic Index for Local Infection. It was felt that diagnosis of local infection, especially by people working in the community, was vitally important, especially in the wake of antimicrobial resistance. So a very detailed literature search was undertaken for criteria that could be used for local infection. And the Tilly diagnostic tool was put together using 6 indirect parameters and 3 direct parameters. This tool was created and then validated across Europe. So patients were seen in various clinics across Europe, photographs were taken and then sent to experts in other centres for diagnosis. And there was 307 patients included in this study. and the validation was found that 22% of these were diagnosed as having local infection. The rest, where parameters were lower, and I am going to talk about this in a bit more detail, these were probably just people who had biofilms in their chronic wounds. So what does Tilly score do? It actually prioritizes early intervention as part of antimicrobial stewardship on a focused approach in wound care. It helps tell the practitioner when they should be starting to look at local treatment and perhaps the use of antimicrobial dressing. So the Tilly actually assesses the wound, identifies early parameters, and sort of helps the actual practitioner look and diagnose local wound infection. So the Tilly score, as you can see, there were 6 parameters chosen: erythema, heat, edema, spontaneous pain or uncomfortable or unusual feeling, stalled wound healing, and an increase in the levels and smell of exudate and colour. There was also 3 direct indications looked at. This was the presence of pathogen, the presence of a septic wound, and the presence of free pus. And as you can see, the at least 5 out of 6 of the indirect parameters are needed to diagnose a local wound infection, and 1 or more of the direct indicators are used. And on the basis of these, if you find you've got 5 out of 6 parameters, you can go down this question and answer this no, yes, and it will help you decide on your treatment. So if you've got only 4 of the parameters, it may well mean that you've got a stalled wound, or you might have a biofilm present. So you still may well need debriding and cleaning, but not necessarily the use of antimicrobials. Let's just give you an example on how to calculate this Tilly score. So this is a clinical case. It was a 21-year-old male referred to community nursing with a category 4 pressure ulcer on the spine. And as you can see, the wound's got slough, it's red, it's oozing, and the wound had actually deteriorated and increased in size for 1 week. The secondary dressing was saturated with exudate. The patient didn't feel well at all, and he was concerned by increasing odour, heat, and pain. So if we were to look at the how to calculate the Tilly score, you are given a wheel, and these are freely available from the company, and you can see there are 6 indirect parameters indicated in green and 3 direct parameters indicated in red, and there are example photographs to help you with your decision making. So the first thing you do is turn the wheel and count the number of parameters present on the wound of the patient. If you have 5 out of 6 of the indirect parameters, then this would indicate a local infection. If you have 1 out of the 3 direct parameters, which are in the red section, that also indicates a local infection. And this would advocate and give you a diagnosis of a local infection and more confidence to actually immediately advocate the use of local antimicrobial treatment. So what's being put together by Ergo is the Silver Toolkit. And this is an information, this is evidence-based, and this is information for you to use with confidence to allow you to diagnose local infection. So we have the best practice statement, which I discussed earlier. You've got information on the diagnostic tool, and you've got this nice key where you can work through. There's also a Tilly Made Easy score, which describes things in a lot more detail. And at the end, you have this nice little circular tool, which actually is movable and can help you with diagnosis. Very small, you can put it in your pocket And obviously then you'll feel more confident when diagnosing wound infection. So let me just talk about clinical evidence. I mentioned it earlier. And I hope most of you are aware of the hierarchy of evidence. And this is used now very much in healthcare. And a lot of people will say, well, where is the evidence that these particular products work? Where is the evidence that this will make a difference to my patient? And if you look at the hierarchy of evidence, if you look at the base of the triangle, this usually starts with expert opinion, and it'll work up with in vitro studies, so studies done in the laboratory. And then you will get a whole case series of studies where people will actually trial them on patients in real life. Cohort studies where different groups will be tested with different, perhaps different dressings, or they might have different wounds. You can get non-comparative clinical trials, comparative clinical trials, but some of the best ones are the randomized control trials. And these are usually double-blinded, and they take an awful long time to do, and they cost a lot of money. If there's a number of clinical trials being undertaken, you can then do systematic reviews, which also help compile the evidence. And if we look at one product, and I have been talking about silver, if we look at one product, ErgoClean AG, I'd just like to describe some of the evidence that is available. So if you have a look across the bottom of this pyramid, you can see a range of tests that's been done in vitro, antibacterial activity tests, etc., antibiofilm tests. And what I've been talking about today is diagnosis of local infection, local wound infection, and how difficult it can be. But not only is it difficult to diagnose, sometimes it's difficult to treat in the community, because we know 80% of these have a biofilm. A biofilm is difficult to disrupt, and the only way we can really disrupt a biofilm is through debridement, cleaning, and application of a topical antimicrobial agent. And what's interesting is if we look at ErgoClean AG, which is a dressing with combined features, so it's made of a polyabsorbent fibers, which will retain exudate. It will also retain slough and other factors that come from a dirty wound. But also, once the organisms are passed into this dressing, the AG component will affect the organisms in the dressing and kill them. But what's interesting, if you just look at the third one along, which is the antibiofilm activity test, this was done using ErgoClean AG, and a mature biofilm of MRSA was actually grown up in the laboratory. And we can do this, we can do these on different features, but this one was grown up. It was 24 hours old, and we applied a ErgoClean AG to this for 1 day, 2 days, 4 days, and 7 days without having any dressing changes. What was found that there was a 4-log reduction in organism numbers, and the biofilm was disrupted using this dressing. Now, if you can do a 4-log reduction with a dressing and also help remove some of the other factors, this will greatly facilitate the healing of your wounds. So ErgoClean AG hasn't just been used in the laboratory, and as you can see, as you go up the pyramid of evidence, it's also been used in non-comparative clinical trials in a variety of leg ulcers, and also shown to help with healing of the wound. So certainly with Ergo, they have put together the toolkit for diagnosis, and they've also produced hierarchy of evidence of their products to actually help with diagnosis. So what I would like to put to you is, how do we change mindsets regarding the myths around silver dressings and ensure appropriate usage? This is vitally important, especially in the wake of antimicrobial resistance. I get asked a lot whether or not there is a lot of resistance to silver. As we find it and as we go forward, there's very limited data to suggest that silver is resistant clinically. We have seen some laboratory data and we found the presence of genes, silver resistant genes, but clinically we have not seen resistance. So it is very important that you choose an appropriate silver dressing for your patient and you use them for the correct length of time. The 2-week challenge is a good way of starting this off. And after 2 weeks, if you go back to your wound and you find that there's been no change whatsoever, there's nothing wrong with then changing to a different dressing. You may well choose a different type of dressing. You may well choose a different method of cleaning and debridement. And you may choose a totally different topical antimicrobial that may be more suitable for your patient. So how do we actually shape the future and change mindsets going forward? It has to be through education and communication. A single individual will not change the future in wound care. We've been talking about silver and silver dressings for many years now. There's been confusion over nanocrystalline silver and silver salts. There's been confusion over diagnosis of wound infection. But what we do know is that the earlier we intervene with any of these wound infections, the better it is for the patient and the better help it has for patients for that wound to heal. Once you get the wound healed, obviously the quality of life for the patient improves, and also then the costs will go down. Let's not forget that it's the need of the individual patient. You must continually reassess their wounds, and certainly in a chronic wound, you must be thinking about debridement. How do I debride a chronic wound in the community? Have I got an appropriate dressing that will help me do this? What about cleaning? You know, do you use saline? Do you use tap water? Do you use a topical antiseptic? Or do you use a dressing that both debrides and cleans at the same time? And then what antimicrobial will I choose? Certainly don't dismiss silver. Silver is an absolutely brilliant antimicrobial. Many of the people who've stopped using silver have done so because they believe the myths rather than relying on the evidence. So I would say to you, pick up the evidence, pick up a toolkit, and then just go forward and help diagnose wound infection and get them healed earlier. So thank you very much.
Brilliant. Thank you, Val. That was really, really interesting. And I know it must be a very interesting topic as well, because we've had hundreds of people watching and lots of questions come through, lots of very kind comments as well. So we'll move straight onto the live Q&A. Do please continue to send your questions in. We'll get through as many as possible during the live Q&A. But like I said earlier, if we don't get through to yours, we will try and answer those in the next few days as well. Okay, so on to the first question. What is the benefit of using a silver dressing that cleans the wound as well as addressing the infection?
I think if you've got something that is very straightforward and simple to use, such as you know, applying a dressing to a wound for a certain period of time, and that dressing actually does the cleaning and the debridement and the application of the topical all in the same dressing, it makes it easier for the practitioner. Otherwise, they have to make a choice on, am I capable of doing this debridement? What shall I use for cleaning? Should I use saline? Should I use a topical antiseptic? Whereas if you've got something all in one, it's following all the features of biofilm-based wound care. And even if you haven't got an infected wound, but you've got a wound that's stalled and not moving on, the actual debridement and cleaning will help remove some of the debris and some of the organisms that's preventing the wound from healing.
Brilliant, thank you. So on to question 2. Does pre-cleaning an infected wound with saline impact how well silver dressings work?
Oh, this is a nice question. Saline is a very ubiquitous solution used throughout the world for all sorts of things. And actually it contains a chloride ion. And the one thing with silver is that silver will bind to chloride ions very, very well, and they form an insoluble compound. And in order to dissociate silver from chloride, it's very difficult and it takes a long time. So a lot of people who do use silver dressings are concerned that the excess chloride ions in saline may well inactivate the available silver ions in the dressing. So what I would say is if you were going to do cleaning, and certainly we're going to use chloride as saline, you do need to think about that. Although often with saline, the levels are so low and the availability of silver is often higher, so you still will have available silver present. Some other concerns that people have with silver dressings with high levels of exudate is the presence of chloride ions in the exudate. But I can tell you most manufacturers do test for this, and they actually put in appropriate concentrations and levels of silver within their dressing so that the availability of silver ions exceeds the chloride ions both in exudate and in saline.
Okay, thank you. Question 3. Would silver help with over-granulating wounds?
It should do, because silver itself is very, very good at inhibiting metalloproteases. So you've got 2 ways that silver works. So if you've got it in high levels of concentration, high levels of availability, we always use words wrong, don't we? But if you've got enough available silver and you've got high numbers of microorganisms, you're going to reduce microorganism numbers. And in that way, you're going to bring inflammation down. But also, silver itself, at certain availability and concentration, actually inhibits a lot of proteases produced by tissue, but also by bacteria. And it's a very well-known matrix metalloprotease inhibitor. So we do know that one of the things that causes continual inflammation, which leads to overgranulation, is the presence of matrix metalloproteases. So silver does have this benefit of being an inhibitor of this.
Okay, brilliant, thank you. Question 4, we have this one's from Siobhan. She asks, we have a particularly challenging PEG site that never seems to improve. Would a silver dressing be appropriate in this instance?
Yes, PEG sites are notorious, but a lot of problems with PEG sites is because you get this acidic sort of horrible environment on the outside. You often don't get the pegs sitting properly, so you get leakage, and this will cause issue and problem, and you get inflammation. Silver potentially can reduce this inflammation, but unless you've got the peg site nicely fitted and a really nice seal, it's not going to be a miracle worker. But if there is bioburden now, if you've got overgranulation due to a biofilm around the peg site, it certainly will help.
Okay, brilliant, thank you. Question 5, is the Tilly score available to use in hospitals or ward level, or is it only used in the community?
No, it's there for general use. It was done initially to help the community healthcare professionals where they needed a little bit more confidence in thinking, yes, this is a local infection. But no, it's freely available for use within the hospital environment as well. You always have to remember that most trusts and most hospital environments have their local policies. And interestingly enough, if you are into diabetes and the diabetic foot, it actually fits in very, very well with the International Working Group for Diabetic Feet. I'm just trying to remember what that stands for. And they categorize local infections. So they use the same 6 parameters as indicators of infection. And they categorize theirs as mild, moderate and severe. And if you look at if we go back to the continuum, it's really about mild infections is where you have some of the parameters, but you don't have, rage and erythema and temperature in the patient. And then you'd have a moderate infection where you would have a temperature, you'd have erythema, you might have infection to the tendons. And in that case, you would certainly always use an antibiotic as well as a topical. And then obviously severe, which would probably be amputation and sepsis. So it does fit in very, very well with the working guidelines as well.
Yeah, brilliant, thank you. Question 6 then is, how often would you suggest changing a silver dressing?
Oh, now that's interesting. That's very interesting, because a lot of the dressings are made to last up to 7 days. And when I say they are made to last up to 7 days, is the levels of silver and the availability of the silver ions are tested up to 7 days. But it would very much depend on the individual nature of the patient. Because if you were to put a silver dressing in place on a patient and it's a heavily exudating wound, you would have to change that dressing at 24 hours. You would just need to. However, you might have a different type of wound that's not exudating, but there's other signs of infection, and you would only really use silver dressings on local wound infection. You wouldn't use a silver dressing on a wound that didn't show any signs of infection. So you would then assess the wound every time you take the dressing off. Brilliant. But certainly you could use them up to 7 days. Some of them have that efficacy.
Yeah, brilliant, thank you. Question 7. If the wound is improving with silver, what is the maximum amount of weeks we can use it for? Well,
a lot of people think you can use it for 2 weeks and no more, and then you've got to stop. And actually, it's down to the clinician. So if you have a wound and you assess that wound after 2 weeks and you notice it started to heal, but it's still got erythema and it's still got lots of exudate, etc., it's still got a local wound infection present, so you continue to use it. But if after 2 weeks you took that dressing off and there were no signs whatsoever of a local wound infection, you would stop using a silver dressing and just use a normal carrier dressing without any antimicrobial, because we have to look at this from an antimicrobial stewardship point of view. We should not be using any antimicrobial agents if we don't need to.
Brilliant, thank you. And you've actually answered question 8 in there as well, so that's perfect. So moving on to question 9. Is silver beneficial for removing slough?
Silver itself isn't. Silver ions isn't. It's usually down to the carrier dressing or the method of debridement and cleaning. What silver will do is, once you've removed the slough and once you've got a nice clean wound bed, you have disrupted the biofilm that is on that wound. And people sometimes get confused with what slough and is that biofilm. And if you think about cleaning your teeth, so if you don't clean your teeth and you get a buildup of plaque, so you get biofilm on your teeth, you can't see that. So these are microscopic organisms living in a matrix. But if you don't clean your teeth, you get a buildup of dead necrotic tissue and old biofilm. So I presume that's what slough is. I think slough, and there's a big study going on at the moment with a Wound Infection Institute are actually trying to really get to grips with exactly what slough is. And, you know, if you can remove the microorganisms that create the biofilm, you're going to reduce inflammation and thus will reduce, you know, extraneous factors that may well be involved in the production of slough. So I can see it being beneficial that way, but not removing slough per se. That makes sense.
Yeah, no, absolutely. Perfect, thank you. So question 10, is it always best to use silver as the primary dressing? In particular, malodorous wounds, would it work well with a charcoal dressing?
That's an interesting point there. I'm not sure if there's any silver dressings that have been placed in charcoal, because activated charcoal, that absorbs the horrible smells, etc. And I'm just thinking here now, because it's just an interesting question. It will reduce malodor because it reduces numbers of organisms, and in reducing numbers of organisms, the amount of volatiles that produce the malodor are reduced in its own way. And there's been a lot of evidence and a lot of papers written to show that when they started to use silver dressing on malodorous wounds, the odor decreased and went away. But using them with activated charcoal, again, it's all to do with the chemistry and how you bind silver, or maybe it's nanocrystalline silver, or whether you bind a silver salt to the activated charcoal and whether that's feasible chemically. So I don't know if there are any dressings out there. So if there are, someone can tell me. But that's how silver will reduce malodor, whereas activated charcoal works differently. The activated carbon in the activated charcoal dressings, actually the volatile compounds absorb and stick, they adsorb and stick, and then they're not released, so they don't go out into the environment.
Okay, brilliant, thank you. Question 11, in cases where the primary dressing adheres to the wound, would using a gauze type barrier prevent the silver being effective?
It may well do. I mean, the nearly all silver dressings that I'm aware of, they advocate that microorganisms are killed within the dressing. Some of them will say they are silver donating, which is where silver will be released from the dressing and go into the surface of the wound. If that is to happen, it'll be an ion and it'll be in a soluble form, so a gauze shouldn't prevent that happening. But the dressing with the silver in, that is the one where that's important, because if it's not a silver donating dressing, it'll not make any difference. So I think the ones that are silver donating tend to be things like the Acticoats and things like that.
Brilliant, thank you. So I think we've got time for a couple more questions. So I'll move on to question 12. Is a silver dressing always the first choice for wound infection?
I would say no. I'm a great advocate of silver. I did my PhD on silver, so I do love silver dressings, but there are other dressings that are available that may be more pertinent to the formulary at the time. So we haven't got to think that iodine dressings are no good, because iodine's an exceptional antimicrobial agent, however can be inhibited where there's a lot of organic matter. There's polyhexamethylene bioguanide, or PHMB, and that works very well. There's no resistance being reported to that, and it works by punching holes in the membrane. And one of the things I would say is that, unlike antibiotics, I don't see, providing the carrier dressing is appropriate for the patient, I don't see why you can't sometimes cycle dressings. So if you were to try silver and you saw no improvement, you may well try a different carrier dressing with a different antimicrobial in after doing the assessment and the wound bed prep. And you may well find that you can then go back to silver. So there are other things out there, not just silver.
Perfect, thank you. Question 13 then, is it advisable to use silver in wounds where there are local signs of wound infection but poor vascular supply, so like arterial ulcers?
Yes, I would. I would certainly choose a silver dressing. And, you know, depending on the state of the wound on that individual, you may well want to choose one that has a cleaning action at the same time. Brilliant,
thank you. And that leads us on to our final question. So question 14, does the silver dressing have to be prescribed by a doctor or tissue viability nurse in a hospital setting?
I don't think so. I think what is allowed on the formulary is decided, certainly as I'm aware now, by the antimicrobial stewardship group, and the pharmacists, the microbiologists, the tissue viability nurses, etc., will decide which dressings are available for use in the hospital settings. But also, I think the matrons and the people who oversee it in the community will also make those decisions, so that if a community nurse was to see someone they thought had had a local infection, as far as I'm aware, those dressings are available on the formulary, and it'll be a local policy whether or not a GP or a tissue viability nurse actually has to prescribe.
Brilliant, thank you very much. And thank you for the session today. It's been really, really interesting to listen to you, and all those questions you've answered as well. I'm sure everyone else will be saying thank you in the comments as well, but a huge thank you from myself and the team. And thank you to everyone for all your questions as well. It's been great to see so many of you watching and get so many questions to ask to Val as well.
Yeah.
So thank you, Val. I'll now sum up the session and just run through a couple of bits to finish off. First of all, if you'd like a copy of any of the documents that Val discussed today, or for more information from Ergo Medical, you can visit their website. That should be on the screen now. It's www.ergostartplus.co.uk/contact-us. So you can get in touch with them on there or contact your local rep as well. So do make sure you follow up and get all the documents and all the studies that we've spoken about today. The certificate link should now also be in the comment section on the screen, so you can use that for your revalidation portfolio. Just make sure you click on that and fill in your details, and you'll get a copy of that certificate. The recording of today's session will remain on our Facebook page, so you can watch it back at any time. It'll also go onto our website along with the slides, and if we have any questions that we've not answered in the live Q&A, we will try and get those answered as well, and we'll add those to the website along with the slides too. Make sure you follow our Facebook page so you don't miss any future events. And we don't just do Facebook Lives and digital events, we do also have our Wound Care Today conference, which is coming up at the end of March, the 28th and 29th of March, and that's in Milton Keynes. So do follow the link in the comment section to that. We'd love to see as many of you there as possible. And I know Ergo will be there as well. So you can find that website at woundcare-today.com/conference. It's free to register for that event, and we'd love to see as many of you there as possible. So that's all from me. Thank you again. Thank you, Val, for a great session. Thank you to Ergo. We really do appreciate your support, and thank you everyone for giving up your time to spend it with us today. We really appreciate you interacting with today's video. Thank you very much. Have a lovely rest of the evening, and we'll see you next time. Cheers.
Okay, thank you.